Good evening, everyone, and welcome to the beautiful Positive Living Centre for tonight's HIV Priorities Election Forum. My name is Paul Kidd. I'm the Vice President of Thorne Harbour Health. I'm also a person living with HIV. I've been living with HIV for more than 30 years now. So it's really fantastic that we have got a great selection of panellists who are candidates for election to address some of the issues for HIV in our community at this really important time. But before we do that, I would ask everyone just to take a moment to pause and reflect about the fact that the land beneath your feet is Aboriginal land. It is land that was never ceded and that was taken from the original inhabitants of this country. And we pay respect tonight to those people. We pay respect to the Kulin Nation people, particularly the Wurundjeri and Bunurong people who are the traditional custodians of the land in this area. And we pay that respect to elders of those communities, past, present and emerging. We also take a moment to remember the incredible work done by so many Aboriginal people in the HIV response and the impact that HIV has had, disproportionate impact it's had on our Aboriginal communities in Australia. So tonight's forum is about the HIV priorities for the Victorian community over the coming 4 years. With the election around the corner, you will each have a copy of this document, and this document, really, I commend it to you. It very succinctly sets out some of the real concerns we have around the governmental response to HIV in our state. We've so much to be proud of about the way we've responded to HIV over the last 30 or 40 years, but there is still so much to do. And as we go into this election, we are really at a crossroads. Yeah. We are at a point in time where there is a plan in place, the Victorian strategy that is coming into operation now, which has as its target the virtual elimination of new HIV transmissions in Victoria by 2025. And that is a really important target. It is within our grasp. It is achievable. We would be the first place in the world to achieve that. And of course, it will happen during the term of the incoming Parliament. So there's probably been few times in our history as a community where there's so much at stake in relation to HIV, and there's so many great opportunities for an incoming government and Parliament to do what needs to be done and to achieve that incredible historic milestone of bringing HIV infections not under control but to a virtual stop. And for people like me living with HIV, that is so important, because HIV itself will not disappear when we end HIV infections. HIV will be with us for as long as we have people with HIV, and many of us are now living incredibly long and happy and productive lives, and it's so wonderful to be one of the survivors of the HIV epidemic. So, with that said, I will introduce our panel, and I'm very, very grateful for each of these people giving up their valuable time. It's an incredibly busy time for anyone who's a candidate for election, and it really demonstrates the attention and the interest in these issues for the three parties that are represented here tonight. I'm going to refrain from making any comment about the party that isn't represented here. But from your right to your left, my left to your right, I'd like to welcome Harriet Shing. Harriet is the Minister for Equality in the Andrews government. She's a member for Northern Metropolitan, and she's well known to our community, of course. So welcome, Harriet. We also have Fiona Patten. Fiona's the leader of the Reason Party very well known friend of our community. She's the member for Northern Metropolitan, and she's also the chair of the Legal and Social Issues Committee in the Victorian Parliament, which is a really relevant committee for us. And thirdly, I'll welcome Dr. Tim Reid. Tim is the Health and Justice Spokesperson for the Greens. He's also the member for Brunswick. So thank you all so much for coming, and please make them welcome. So there's a series of questions that I'll be asking, and there's also an opportunity to have some questions from the floor later on. We'll also potentially have questions that may have been sent in by email, but I'm not sure if that's happened. And this event isn't going out live. It is being video recorded. If you do want to ask a question later on, I'll ask you to wait until a roving mic is brought around to you so that we can get the audio for the question, but you won't be on the video. So you needn't worry about your face being on a video. And of course, if you would prefer not to be recorded at all, just say so, but don't let that put you off asking a question. We'll just take that out of the recording. So I'll start with a question for you, Fiona. How will, and I'll ask each of the panelists to confine your answers to about 3-4 minutes. Yeah, well, I'll give you a wrap up at 5. Fiona, how will Reason use its influence in the Parliament to achieve positive HIV-related reforms in the next term of government?
Thank you, Paul, and thank you to Thorne Harbour for having this really important forum today. And thank you for your excellent acknowledgement of country. And I would also like to acknowledge the Wurundjeri Woi-wurrung people of the Kulin Nation and pay my respects and recognise that this land was never ceded, always was and always will be. And as you were talking about this and we were talking about the history around HIV and AIDS, I couldn't forget Condom Man, which was one of the best First Nations campaigns, and it was a cartoon character. And it shows my age, if my face doesn't already, particularly under these lights. Thank you for the fluoros. I actually have just come back from Canberra today. I decided back in July that the best thing to do the week before the election day was to go to Canberra to speak in a conference. But it was a conference on stigma, and it was run by AVIL, the Australian IV League, Intravenous Drug Users League. And they were celebrating 30 years, and I realised as I looked around the room, I had known these people for more than 30 years. I'd been involved with I joined the AIDS Council in 1988, I think it was. They look back on it and regret that they took me onto their board around that time. But that was what got me involved in politics. I think HIV and AIDS is actually why I am in Parliament today. That was what got me political. It was the discrimination that I was seeing at that time. So in asking that question, how will I use my influence in Parliament to achieve positive HIV-related reforms, it's kind of the reason I came in. And I remember actually being fortunate, being the acting president, to stand up and say that the repeal of 19A of the Crimes Act was passed. And Harriet and I were both new members of Parliament on that day. But so I will continue to work to change those reforms. I think this very sensible document that you have created here actually does lay out a pathway, because back then, like, the thought of U equals U was just like, I mean, we talked about just pretend everyone's positive, don't get tested because of the impact on your life of finding out your status. Just assume you have a positive status. Just assume everybody else does, because if you don't and you go and get tested, there's not much for you. Now that's different. Now we are talking about U equals U. We are talking about undetectable. So we are talking about, a condition that we will live with. And a condition that should not be considered extraordinary under our legislation, a condition that should just be considered a chronic condition like many others that is manageable and should not be discriminated against. And I think this document lays that out. I've been fairly effective in campaigning on things that I think are important, and certainly going forward there's some unfinished work to be done on sex worker law reform. And the government did decriminalise sex work in a really productive and pro-sex worker way, but there's more to be done. And, you know, if we don't keep that momentum, if we don't keep people like, actually the three of us really, I don't think you're going to find much of disagreement up here from the three of us, but if we don't keep pushing to ensure that that happens, it might not. The same with drug law reform, the same with ensuring that even our Charter of Human Rights has some teeth that can work on this. And I've been doing some work on anti-vilification legislation to ensure that our anti-vilification laws not only protect people on the grounds of their race and religion, but also on their sexuality, on their gender, on their disability. And that will have an impact, a positive impact, I hope, on our HIV and AIDS, HIV community. So, yes, I'm there, I'm present, and as I said at the outset, HIV is probably the reason that I got political and the reason that I'm currently in Parliament and currently seeking re-election.
Thank you, Fiona. Next on my list is Tim Reid. So luckily that's the person with the microphone. So Tim, if the Greens form the balance of power after the next election, what are the HIV priorities that you will push for in negotiations to form a government?
Thank you. So, balance of power, have you ever tried to roll a ball along a table and to get it to stop at the edge? Right? Sometimes it happens, but most times the ball doesn't go anywhere near the edge, or it goes over the other side. And that's a bit like balance of power, right? Because it requires the Conservative and Progressive parties, Labor and Liberal, to have a roughly equal number of seats before balance of power comes into play. So it's actually not terribly likely at this election, I wouldn't think. But then I've been proven wrong in most elections I've run for and trying to predict the outcome. So who knows? And so the reason I mention that is because the Greens and other non-government MPs who are not part of the Liberal National Party opposition have various ways of influencing outcomes. And so I might mention some of those in a minute. But to go straight to the question, there's a bunch of issues on our platform that will clearly be top of our list, but really all of our platform will be on the table in any negotiations we have with the government. It may well be that things that are a fair way down the list are more achievable because they're of more interest to the government than some of the things near the top of our list. And so let me just single out one of those in particular, and that's public housing. And public housing doesn't immediately leap perhaps to front of mind as an HIV priority, but anyone involved in healthcare knows the importance of public housing, and particularly affordable housing in general for a growing percentage of our population. But I'm singling out public housing in particular because those of us involved in healthcare have all had clients, we've all had patients who need accommodation and will not get it unless they get public housing. They're out of jail and they're going to be in a boarding house, under a bridge, on couch surfing, or they'll be in public housing. And the public housing waiting list is well north of 100,000 people in Victoria, and it's been rising over the past few years. And so I'm just going to put that at the top of the list because one of the reasons that I think is going to be increasingly relevant with HIV is as we move towards the virtual elimination of HIV, the pockets from where HIV has not been eliminated will be in what are known as hard-to-reach populations. And that could variously be for some First Nations people, non-English speaking people. It could be people with substance abuse issues, mental health problems, and homeless people. And the Venn diagram of a lot of these groups overlaps in a lot of places. There's a lot of people who have multiple sources of disadvantage, and to expect them to participate in an increasingly tight private rental market is just too much. Hence, public housing. And I'll just quickly dot point a few other priorities. Having worked for 20 years as a sexual health physician at Melbourne Sexual Health Centre, I'm probably a little biased, but Melbourne has one significant public sexual health centre, and Melbourne is big enough for more than one. And so we need to increase expert sexual health services around Melbourne, whether that's another centre or whether that's increased capacity in some public hospitals involving perhaps outposts of Melbourne Sexual Health Centre or whatever. But it needs a serious investment in expert sexual health diagnosis and treatment, and that needs to be done in both, to the east and the west of the CBD. So a couple of other very quick dot points, and then I'll hand over the microphone. But we have one brilliant medically supervised injecting room. We need more. They don't necessarily all need to be Taj Mahal type institutions like the one in Richmond. We could have some smaller pop-up or mobile type ones, but we need more of those facilities to stop people dropping from heroin overdoses, but also for the ancillary services they provide around hepatitis C treatment, dental care for drug users, and reducing the transmission of bloodborne viruses. And I would like, and I might mention later, some other areas of reform in the alcohol and other drug space. But condoms and clean needles in prisons would be another one I'd add to the list.
Thanks, Tim. And Harriet, if a Labor government is re-elected, what will be your government's HIV priorities?
Thank you, Paul. So I just want to say at the outset that neither of you spoke for 3 minutes, so I see that as open season for me. Whatever. It was indexed for inflation, so that's all right. Okay, so my name's Harriet. And we don't have time limits in the upper house, but I'm going to respect the protocols, Paul, that you've introduced this evening. No, we don't. Harriet Shing, she, her, Member of Parliament for the Eastern Victoria region in the upper house alongside Fiona. I want to begin also by acknowledging the traditional owners of the land upon which we gather tonight. I pay my respects to elders past and present, and I also want to acknowledge any and all Aboriginal or Torres Strait Islander leaders or emerging leaders who are either here tonight or who might be seeing this video down the track, or indeed who are part of our extraordinary sexual health movement and of community in making sure that we can have culturally safe conversations about sexual health, about well-being, and about community participation. So, we have come a long way, and I think that that's broadly acknowledged, not just here on this stage, but across our communities. We have achieved the almost unthinkable in terms of how far we've come with U equals U, the availability of PEP and PrEP, and the way in which we have worked alongside, not without difficulty, but worked alongside the federal government and across our community and public health sectors to really lean into what it means to be able to prevent and to reduce risk on the one hand, to provide effective care, treatment, testing, identification of what is needed more broadly, including as far as secure housing, including as far as adequate access to needle exchanges, including as part of culturally safe sexual health and overall opportunities to participate. We know that the stigma attached to HIV has been debilitating for so many people, and that this has persisted over decades, including for those who are no longer here. And these conversations, I think, always need to include an element of grief and of loss and of respect for those who endured so much suffering, so much avoidable trauma because of the prevalence of stigma and discrimination. So that infuses every part of people's lives. And we know as LGBTIQ plus people that we already face this persistent idea of being other, and that in turn affects our participation in a whole range of ways in our communities, in employment, in accessing sexual and general health services. And that's compounded further when you live, for example, in rural and regional Victoria, if you're from a culturally diverse community, if you're a member of a First Nations community, again, if you're within the intersectionality of our own communities, if you live with disability, if you're neurodivergent. And I also want to acknowledge our trans folk as well. It's Trans Awareness Week this week, and I think it should never go without saying that we need to do more, and we need to be visibly doing more to acknowledge the layered trauma and distress that issues such as HIV present to various parts of our communities, and that we should always be striving for inclusion. So I'm with you, Tim, on housing and what that means as far as vulnerability to insecure housing and accommodation. We've done a range of things to provide access to specialised LGBTIQ plus caseworkers and referral mechanisms. We announced that just a couple of months ago in Drummond Street. We've also been working on sexual and also reproductive health opportunities, not just within Melbourne but further afield, and relying on our public health units has been a big part of that. So adding additional resources into that is something that we did rather coincidentally but conveniently, I think, for the straights out there within the COVID dynamic. And we had an opportunity to pivot into providing better access to services through that pandemic and the pandemic response. So we have an opportunity to continue toward virtual elimination. I really look forward to the point at which we can have that bookend. But it's not the end of it. We've got 10,000 recorded cases in Victoria. Last year we had 140. So that's the third lowest, I think, since records began to be kept back in 1983. And it's then about saying, how do we make sure that we're identifying where those areas of risk present? How are we managing the prevention and reduction of risk, and providing access to really good treatment and to assistance with the sorts of support that people need, including in culturally diverse formats as well. We know that international arrivals, visitors and community members are overrepresented in that dynamic of 140, for example, for the 21 year. And again, that's about providing culturally relevant access to materials as well. So in short, not at all, that was in long. It's about making sure that we lean into every part of culture and of engagement that provides opportunities for co-design. And this is where over the last 8 years we've had multiple working groups, a task force, an LGBTIQ plus strategy, an HIV plan, which was released just last month. And this is about making sure we continue to peg our way toward better outcomes, but also really durable outcomes. They have to be able to withstand change, including as our populations grow, including as our borders open, including as we lean into really just getting into the idea that stigma is persistent and it's insidious and it appears in all sorts of ways, and recognising that and leaning into it is part of often very uncomfortable conversations for governments, for agencies, departments, and indeed the private sector, and making sure that we address that across the entire system of provision of health services, but more broadly services that deliver on recognising the importance of good quality of life. 3 minutes, bang, straight on it.
I think you might have gone slightly over 3 minutes, but it's okay because the Liberal candidate hasn't said anything.
Oh, I know. How surprising.
Harriet, hold on to the
Sorry,
microphone.
yes, of course. Yep.
Next one is directly to you, and this is a question for each of the panellists in turn. So the COVID pandemic has, of course, put our health system in Victoria under a great deal of strain, and that's been very much in the news and in everyone's minds over the last few years. But it also highlights how overstretched our health services already were before COVID, and in particular the lack of accessibility for people in outer metropolitan areas, regional and rural areas, and particularly to sexual health services and HIV services. So what can we do to improve access and uptake of HIV testing and treatment in Victoria?
Thank you. That's a really important question, because what it does do is take the reality of a post-COVID environment and examine the things which it brought to light, which were perhaps not as glaringly obvious before we hit those high case numbers, before the health system was exposed to a tremendous amount of risk and pressure. At the outset, our health workers were and are at the very heart of our frontline response. In the course of the last 8 years, there have been 26,000 health workers recruited by the Andrews government, and there's been a plan announced, which you may have heard about in the last couple of weeks, to recruit an additional 24,000 nurses, midwives and healthcare workers. And that includes things like paying for the degree and sign-on bonuses within the public system. This is also, though, about providing culturally appropriate and culturally safe treatment and assistance and care to clients, patients and consumers. And one of the things that I've been pretty vocal about is the fact that every part of the community comes with its own bias and its own prejudices and these inbuilt ideas about the opportunity to judge. And that's every sector. It's every part of every service and decision that we access in our everyday lives. And that's where I think that healthcare worker training and guidance to actually improve the awareness of stigma, of vilification and discrimination is crucial, not just as part of being a better practitioner, but as part of allaying concerns that then might lead to non-disclosure of concerns or fears for that patient or client or consumer. There have been, as I said, a range of initiatives that we have actually been able to deliver in the context of the COVID response. So it's about $3.25 million, I think, to be able to expand the access to sexual health services across the state. So to go beyond the central Taj Mahal clinic, I think. Oh no, you referred to something else as the Taj Mahal, but being able to actually have those services embedded. And we also know that community-led services are really important as well. We know that the preparedness of our communities to come forward and to get tested and to access services and indeed to connect with opportunities to address current and future challenges or vulnerabilities is really important. And when I think about Thorne Harbour Health, you think about Drummond Street, you think about a whole range of services that are very specifically geared toward our communities. These are the sorts of things that matter, and this is where the LGBTIQ+ strategy comes in, which is about services in place that are tailored to our communities and what it is that we need. So, public health unit access to information, testing and treatment, prevention and good community-based information on awareness. And we're really good as a community at being aware, but there's always more work to be done, particularly when we get to You Is You, and particularly when we move toward virtual elimination. Again, it's about pushing back against the risk of complacency. And this is the same with any kind of health issue, and we just need to make sure that we manage it as we manage any other health issue, but recognise the disproportionate disadvantage that we see throughout our communities because of stigma and discrimination. So it's about having a whole government approach to the delivery of services. tailored and specified within communities, co-designed wherever possible, reaching into various parts of the state, so hub and spoke sort of models for public health delivery, and making sure that our healthcare workforce and specialist workforce is adequately equipped and also not confined to the middle of Melbourne. Thanks.
Thank you.
3 minutes again. Look at again. Amazing. Fiona, take it away. Take my microphone.
Yeah, I know.
So same question
Look,
for you, Fiona.
I know Harriet's taking up the time that the Liberal Party may have spoken, but I'm not sure that's what they would have said. So, in fact, I think that's actually a very important point, because one of the ways that we can ensure that we have good access to testing, good access to treatment, with protections from the stigma and discrimination that I too readily remember from years gone by that sat alongside that testing and treatment, is to be careful what we do in the ballot box. Harriet and I have been talking about it. Tim, sorry, we're just talking about the upper house, like your greenhouse. So, I don't know what goes on down there. We passed the legislation. We're the boss of you. But up there, it can get pretty tricky. And up there, we could see some really conservative people elected. So please be careful when you vote. Actually, vote 1 to 5 below the line. Do not let anyone direct your preferences. Because if we see a conservative upper house, if we see the builders, what are they called? City Builders Church. I mean, who came up with that name? Because I don't think that, well, no, they're part of the Liberal Party. But these are dangerous to our community, and they will take us back. And if they have balance of power in the upper house, which actually could be quite possible, we will not see the reforms that we need. So just on that. But second, given the preamble that you gave, Paul, which was around COVID and how we saw that stretch, it's interesting that we all, I think, had a greater appreciation of testing and a greater understanding of what testing meant and the importance of knowing your status, whether that was your COVID status or your HIV status. And we know the earlier that you know your HIV status, the earlier you can have treatment, and the better that your body responds to that when you haven't had time for antibodies to multiply. So early testing, and I know we've seen a lot of rollout of this in our community, but home testing, we're now quite comfortable with home testing. Probably prior to COVID, that all seemed a little bit tricky. It seemed a little bit unreal that we would actually do our own home testing, but we can do that now. And that gets us into treatment early. Tim, you were quite right. Like, we've got a great sexual health clinic. We've got one brilliant sexual health clinic. For someone in regional areas to get good testing or to get treatment straight away, to have a doctor that says, right, positive testing, let's not wait any longer, let's put you on antiretrovirals right now. We need that to be spread into our regional areas. We need to be equipping and educating our doctors. That needs to be a role of government to roll that out, because if we are going to get to the elimination, we have to do that. The earlier we detect HIV, the quicker we can go towards elimination. I think just on that is also about enabling nurse practitioners, enabling pharmacists to play a greater role in this, because we know our GPs are stretched and we know our health system is stretched. So let's look at the alternatives. If we're talking about, particularly if we're talking about PEP or PrEP, let's actually enable nurse practitioners, let's enable pharmacists to do it. It took us decades to do this for the morning after pill, literally decades. I remember having to go and find some doctor, okay, it was a big night, but find some doctor somewhere in a town that I didn't know where I was to get the morning after pill and to go and talk to someone. Now, with that shouldn't be the case. It actually should be over the counter. And that we should be working towards that. Now, I know that that's not just a state matter. I know that requires some federal changes as well. But let's work towards those. Let's work towards making sure treatment, prevention, testing are all accessible. And as I say, COVID has actually shown us that we can do this, that we can look at prevention through vaccination. And for us, that's through, or for HIV, it's through PEP and PrEP. And I still kind of get goosebumps that we are talking about this, that we are talking about ways that we can actually prevent HIV because, as I said, I've just come back from a conference where we were celebrating 30 years and we were saying the same things about stigma around drug use. But in HIV, we're not saying the same things. But the other point, just finally on that, is those groups, again, that Tim mentioned, the people who don't have access to PEP and PrEP because they don't have a Medicare card or they don't have the resources. Those groups, we need to change that. We need to mean that everyone, whether you're an international student, whether you're on a bridging visa, whether you're on a permanent resident visa, or whatever it might be, that you also can access. And also possibly for young people, how can young people be able to more easily access treatment, but also be more easily to access testing?
Thanks, Fiona.
Thank you. Does Harriet want a glass of water as well? There you go. Look, you might. So, I think the question was about HIV testing, wasn't it?
So it was about improving access
Yeah.
and uptake of testing and treatment.
So I don't think home testing is as widely used as it should be. And so we know from the fourth study that gay men offered access to the OraSure, OraQuick test, tested more frequently than a control group. And that was the first study that showed some kind of new testing technology led to an increase in the rate of testing. We know that just access to rapid finger prick testing alone, with no other change, didn't lead to any increase in testing frequency, nor did giving people a bit of paper that says, go and, a pathology request form that said go and get your HIV and syphilis test whenever you want, didn't lead to an increase in testing frequency. So there's something special about the oral test. But the thing that's probably driven a lot of testing frequency and getting newly diagnosed people onto treatment has been PrEP. Because if high-risk people are on PrEP, they're turning up to get their script filled and they have an HIV test when they get their script filled. So this, and I think this might lead into your next question, but getting people in need onto PrEP is probably should remain the priority here, I think. But I'd be really interested to see and to support increased use of home testing, particularly for those groups we've mentioned before. For example, students, a gay student coming out from a conservative country like Malaysia. Those groups might find home testing more acceptable. And so in order to get testing up to very high levels so that there are very few undiagnosed cases is the goal. And so I think that the only other barrier that really needs to be addressed is ensuring that people who don't have permanent residency, don't have Medicare access, can still get free STI and HIV testing whenever and wherever they want it. That's not currently the case, and it should be. I might stop there.
I'm going to go off script for 1 second and just ask a question that I'd really like to hear the answer to. It's not on the program, but just ask you to all be really, really brief. I'm someone who lives in regional Victoria, and access to health services is perennially less good in regional Victoria than it is in the city. But in particular in relation to HIV medications, for those of us who take those medications, if you get those prescribed at a pharmacy other than the Melbourne Sexual Health Centre, you have to pay a co-payment. If you live in Melbourne and you're able to go to the Melbourne Sexual Health Centre, you can get your HIV meds for free. It's a drug that all of us take on an everyday basis. They're non-negotiable. Do you think it's fair that people in the regions don't have access to free, co-payment-free medication? They've had this in New South Wales since 2015. Why don't we have it in Victoria?
I think he said free.
Oh, man. Do I think it's fair? No. What do I think we need to do about it? Make sure that we're continuing to work again alongside the federal government. We got the PBS listing back in 2018 after really, really lengthy, difficult lobbying and advocacy efforts. It's then about making sure that we can continue to, advocating for it is what I'm saying, that we had got that position as a state to advocate for it.
New South Wales government's been paying for this for 7 years.
Yep, so... Yep.
We've had this discussion for years.
So, I'm very happy to take a question should you want to ask one, but what I will do is just say we need to continue to provide opportunities for people across rural and regional Victoria, again in the way that I said in my opening remarks, to the same sort of equitable access that people in the middle of Melbourne comparatively have access to. So the tyranny of distance is a really significant factor in disadvantage across a whole range of metrics, and this is why again there have been a range of programs and initiatives that are about making sure that people can access good health care by actually incentivising people to work in rural and regional centres, about building up the infrastructure that exists in rural and regional towns and centres, and about using things like population growth to make sure that we are decentralising access to services across the board. Telehealth is another really important part of that work, and this is where again I think we've gotten better through forced innovation because of COVID. Previously it was all too difficult to get access to telehealth appointments, and now all of a sudden it's considered to be the norm, in the same way that an oral test for COVID is now something that the nasal swab is something that we don't actually think twice about, and telehealth as well is coming along that way too. So again, access to those appointments to overcome that distance is also a part of those sorts of innovative solutions that can and indeed I think should be pursued.
I agree. I think the co-payment does need to be, there needs to be a state government contribution. It's actually because when someone can't afford that treatment, when they can't afford their daily medication and they become sick, it's actually the state that ends up picking up the cost for that. So it's in our interest to pick up that cost. And I would just add to that, while I've got that, is the same goes for opioid replacement therapies. So we've got people paying, up to $70 a week. And I mean, Jesus, if you're in a regional area, you're lucky to even find someone who will give you methadone or buprenorphine or whatever treatment that you're looking for. And then you're paying a $7 dispensing fee, sometimes up front, so you're being asked to pay a $50 fee up front. We know many people with chronic conditions are not working, are not earning full-time wages. So I can see that, on balance, it is a no-brainer for state governments to subsidise those costs, so to pick up those co-payments for HIV and AIDS treatment. But I would also add that I will be campaigning for the same to happen for opioid replacement therapies.
Thanks, Fiona. I'll join you on that campaign. I mentioned earlier that non-government MPs can do some things, and so one thing, and it should have occurred to me more than before today, but it's just occurred to me tonight sitting up here, that Fiona and I could do is get a costing, find out what it actually costs. And the Parliamentary Budget Office is a resource available to non-government MPs, and so we'll ring them up and get a costing on. And the reason I mention that is it might actually cost us less than we think, for a couple of reasons. First of all, the federal government has just cut the size of the co-payment from $40 to $30, the maximum co-payment. So that's a slice taken off the top. The other thing is that a lot of HIV medications are now being combined into, 2-in-1 pills and things. And so the total pill burden is shrinking, and that has some paradoxical effects in reducing the size of the co-payment as well. We've got a costing on the co-payment for contraception recently, and Victorians buying PBS contraception spend about $2.5 million a year on co-payments, and that's nothing for a government to cover. So that's actually because there's a bunch of contraceptives that aren't even on the PBS, but for those that are, it's far less than I thought. So we'll get a costing done, see what it is.
Thanks. We're going okay for time, but we are going a little long. So, and I want people to have the opportunity for questions at the end. I want everyone to be able to go home on time before midnight, and so we'll try and keep them to 3 minutes. Okay. I'm not going to time you because it's too technically complicated for me, but let's go for 3 minutes on this one. So this question's about biomedical prevention, and that of course includes PEP, post-exposure prophylaxis, PrEP, which is pre-exposure prophylaxis, and U equals U. But in particular, the introduction of PrEP onto the PBS in 2018 has greatly, it's completely changed the landscape for HIV prevention in Australia. It's now probably our central tool for HIV prevention. It's contributed to the reductions in HIV that we've seen. So starting with you, Tim, how can we ensure that people have convenient and affordable access to PrEP and to other biomedical prevention for those people who need it?
Yeah, thank you. So I've already talked a bit about PrEP, and so just to reiterate that it's really important that we identify those groups with reduced access to PrEP, and I'm particularly thinking of culturally and linguistically diverse populations, but others as well, indigent groups and others who have reduced access, and work out what needs to be done to get it there. And that will involve particularly, for example, outreach services, I think, into those populations, because that's where we need to go if we want to get to virtual elimination of HIV. But I've scribbled down a couple of other notes. One of the game changers with PrEP is going to be the potential role for long-acting injectables like cabotegravir, and I don't think that's on the PBS yet, but we're in this Mexican standoff between the drug company and the PBAC, and it's always resolved in the end. Just how long you have to wait is the only question. So that will become available, and that will be useful particularly for people for whom adherence is a problem, and so that's another group where there will be improved access. But I think there are a couple of other things that we forget, and one of them is that access to condoms in high schools and prisons is, it's biomedical, it's just not normally talked about in that bracket, low tech, and worth investing in, cheap at the price. And I think, in the interest of time, I'll hand over to Fiona. Yeah.
I think I touched on this in my previous response, but certainly, again, looking at those pockets where it is not easily accessible, and those are people who have come from overseas who can't access it. The cost for them for PrEP is, we're looking at hundreds of dollars a month. So those are areas that I think we need to work on and look at how we can subsidise in those areas. I think touching on Tim's, also people knowing that it's available, knowing that PrEP and PEP are available is important, and certainly for young people. And let's face it, our sex education in Victoria is still appalling, and we really need to improve that. We need to be talking, PEP and PrEP can be part of that, and in fact, sadly, that's probably, scaring children, scaring young people about sex is generally it seems to be the objective of sex education in our schools. We don't talk about pleasure, we don't talk about alternatives to penetrative sex, we don't talk about a whole range of issues which I'd like to see us talk more about. But I do think, just going back to the question that you asked, it is those pockets where people can't access it, and that's where I think we need to focus, and we need to be subsidising. And again, we know the cost of preventing someone from contracting HIV far outweighs the cost of treating someone with HIV.
I'm going to be really quick, uncharacteristically for me. So I think that this is one of the best examples that I can think of stigma, that it is all too easy to treat HIV treatment and the availability of treatment and care and access to services because of the fact that for too many people, there's still a grim reaper in their head when they think about it. So this is about understanding that we've come a long way when it comes to everything from chlamydia to hepatitis to gonorrhea, syphilis, whatever you want to talk about. We have a better level of literacy on these things than before, that at a school level people are able to talk about these things because they've had that nasty shadow taken out of them over time. And I think that is persistent with HIV. And I think that comes with all sorts of knock-on effects, whether it's decisions around medications and treatments that are available, the cost of those things, the steps that one has to go through in order to access them, and the way in which resources are made available in that prevention message, in that risk management message, that this is to me a really significant example of how we need cultural change and how that needs to drive the conversations that we're having, so that at the very least we can continue to improve the literacy of this condition beyond our communities. We know what it means. We have different views about that within our communities, but we still actually have very close connections to HIV in our communities. And for many people, if you don't see it, it's out of sight, out of mind. And I think that that's part of the public education work that needs to continue there too.
Brilliant, thanks. Brilliant timing, everyone. I'm just well done. Next question, we'll start with Fiona. And this question's about drug use and harm reduction. So since the 1980s, we've been incredibly successful in Australia in preventing transmission of HIV through injecting drug use. And in April next year, Melbourne is going to be hosting the International Harm Reduction Conference for the third time. So the question for each of the candidates, what's your party going to do to further reduce and maintain preventable HIV and hepatitis infections and drug-related harms in the next term of government?
It's interesting, we do pat ourselves on the back about how good we were on harm reduction, and we were. Back in the 1980s, when we were looking at HIV and AIDS coming to our shores, we did respond quickly. We did do well. We were one of the first countries to set up needle and syringe programs. I volunteered on a mobile syringe bus, needle bus in the 80s. But the other countries have gone way ahead of us. And first and foremost, it's around drug decriminalisation. While we still criminalise people for using drugs, it is very hard for them to access safe information and access drugs safely. So decriminalisation, and certainly I put up a bill this year that wasn't successful, but I do think that Victoria is at a tipping point. We have, we hear everyone saying we have to treat drugs as a health issue, not as a criminal one, yet we keep treating it as a criminal one. That has to change, and I'll continue the work there. Look, our supervised injecting room has been, despite what you read in the Herald Sun, Please don't read the Herald Sun. I know. It has been an enormous success. And when you look at the pathways to treatment, when you look at the pathways to health that centre has provided, it's been extraordinary, and it has changed people's lives, and we need more of them. And I agree with you, Tim, they don't need to be a Taj Mahal. They do need to be a simple overdose prevention centre. But the other area that I think is a game changer and is something, you know, we tried heroin-assisted treatments, or we tried to get them, we never got them. They are extremely successful. This is where you provide someone who needs to use heroin every day with the heroin they need to use. And remarkably, this means that they can use it safely, they can get the wraparound services that they need, and quite often this is a pathway to a different life. For us, it's hydromorphone, which is an analogue of heroin. For many heroin users, it has almost exactly the same impact and effect, but you're not buying it on the street. You're breaking that cycle with criminality. You're also getting those wraparound support services when you're using it, and this again enables us to prevent HIV and hepatitis infections. Needle syringe programs in prisons. The evidence is there, the research is there, we have to do it. We have to break this nexus with the unions, which seems to be the only reason we don't have them in our prisons. And I mean, I've always thought one of the backdoor ways of doing this would be to insist that prisons actually do pre and post testing. So you test someone before they come into prison and you test them after. And the minute you did that, you would find prisons taking a lot more attention into ensuring that while people were under their care, they did not contract hepatitis, they did not contract HIV. So I think there's lots of ways to do that, but obviously destigmatising drug use is crucial to that. Oh, pardon me.
Harriet, next. I don't know how these orders would...
It's organic. It feels like it's evolving as we talk. I think what we need to do is to continue the work that has begun, as Fiona's indicated, in providing needle exchanges, in providing better access to health and medical information, and reducing that prejudgment that too many intravenous drug users have encountered time and time again when seeking access to information about how to clean and sterilise, about how to inject in a way that will minimise the risk of overdoses. Also, being able to access healthcare when and as overdoses occur sits alongside the medically supervised injecting centre and the work that it has done. And the statistics, you're right, Fiona, do show that hundreds of overdoses have been prevented. And again, whatever you want to read in certain newspapers, the bottom line is that these people who are overdosing, they're loved by someone and by many people, and it's all too easy again to reduce people to statistics and to two dimensions, and for that then not to be something that's personal. So I think that we have a good basis upon which to build on that general improvement to community awareness about how intervention and prevention can work together, and then also to move from that into what ongoing treatment and wraparound care looks like. And I'm not here to make any announcements about what you're looking for. I know that's right. Much as you may wish to see that, I think we've come a long way. I think we've got a long way to go. But again, it's about resourcing our sector. It's about the health and human services sector. It's about making sure that we have good access for drug users and for the ones who love them and care about them, to be able to provide them with everything from needles through to information, through to help when and as they need it. But it is about wraparound. It is about, again, leaning into the reality that drug use is and always will be, and what that means for a community is a measure of that community's maturity and preparedness to face the importance of early intervention, of prevention, and also of loss and risk management as well. And I know that sounds, I don't mean for it to sound crass. I don't mean for it to sound like a statistical exercise. That's in fact the opposite of what I'm saying. But governments think in terms of very large decisions, and therefore it's also useful to say, well, the Productivity Commission does look from time to time about the cost of human health interventions. What does that look like, and how can we, if we're taking an economic lens to this, how can we in fact say that there is a better benefit in socio and economic terms in an early intervention process that looks at a range of opportunities to come together in different ways?
Thank you. So, well, as you've heard, full marks to the government for setting up a medically supervised injecting room and planning to set up a second one somewhere around the CBD. And yes, and Fiona's made a contribution as well as others. So but unfortunately the government's gone backwards in terms of one of the other major drug-related harms, which is imprisonment. And the population rate of imprisonment in Victoria is about double what it was at the turn of the century. In fact, to go back in history and see when were we jailing Victorians at a similar rate, you have to go back almost to Ned Kelly's time. The big increase in the number of people in Victoria's prisons, almost all of the increase over the last 8 years of the Andrews Labor government has been in unsentenced individuals, because the prisons are being used as an expensive waiting room for the courts. A lot of those people are there for drug-related offences. And prison is a brutalising experience. People come out worse than they went in. And so if this government is serious about reducing drug-related harm, we will see decriminalisation of possession and use of small quantities of drugs. We will also see bail reform. Because right now, reoffending while on bail is a ticket to prison. And one of the commonest causes of reoffending while on bail is drug offences. So that's a clear black mark against the current government, and one that non-government MPs like me need to point out, just so that people understand it. In terms of other things, as Fiona's already mentioned, we need to subsidise methadone. That's critical. We need pill testing and needle exchanges, needles, condoms in prisons. I'll stop there.
Thank you. We're going to finish up just a little bit after 8. There is one last question on my sheet here, but also there'll be some time for questions from the audience. This one does say time permitting, but it's also about HIV criminalisation, so I'm definitely going to ask it. But maybe we can do this in a relatively rapid fire way. Yep, happy to do it in whatever order. So this is about Section 45 of the Crimes Act, and for people who may not be aware, we were really successful in repealing Section 19A of the Crimes Act a few years ago. Tribute to Eden Muchamore, who's in the audience, who did a lot of that work. Section 45 makes it an offence to procure a sexual act by fraud. And what we've seen in a number of cases with people with HIV is that people have been given criminal convictions for not telling the truth about their HIV status. We know that people don't tell the truth about their HIV status for a lot of reasons, and those include reasons related to their own personal safety, because it's not safe to disclose your status in every circumstance. What can we do to reform the law, to end this remaining form of criminalisation, and to protect people with HIV, to protect their privacy and their safety, and to protect them from criminalisation?
So I support repealing that section, provided adequate precautions have been taken to prevent transmission by the person. So I think that that's pretty simple. I think that there are some other areas where we can look at some law reform or bureaucratic reform to reduce stigma. I won't enumerate them all, but I'll just single one out, and that's the waiting period for blood donation for gay men, which and sex workers as well, has reduced from 12 months to 3 months, I think, recently, since last episode of sex. But it can go to less than that with modern testing technology. There are a number of ways in which it can be done. I won't waste time going into it now, but I'll just identify that as a priority. I've been trying to push previous health ministers to do this, and I will continue to advocate in that space.
I certainly don't want to get rid of this whole section. I think procuring sex by fraud should remain, but we do need to carve out HIV status from it, and we need to carve out HIV from it. And when you look at what we've moved enormously on the sex work reforms. So in the government sex work legislation, we finally got to the point where we recognise that you can be HIV positive and be a sex worker. It's not mutually exclusive, and the legislation has stipulated that, and we've managed to carve that out of the Sex Work Act. So it's not a big step to carve it out of Section 45. I do think obtaining sex by deception and fraud actually still is a pretty shitty thing to do. But it just on that, I think there's lots of areas of legislation that we can fix, and more generally, I think it's around some of the gendered language that we use in a lot of our legislation, removing those. There's a whole raft of areas. There's obsolete legislation. Rather than, we should have a repeal day. Like once a year, we should have a day where we repeal all of the bad laws. We make so many every week. We pass 3 or 4 bills. So how about we just have one day where we try and get rid of some? But certainly recognising that, ensuring that no one could be charged under this act, under this section of the Act, just because they were HIV positive. And I think that's a fairly simple amendment, and it's something that can be absolutely done. And as I say, the Sex Work Act shows us the way forward, shows us that we have moved on from that, shows us that we don't see just being HIV positive as equaling they're going to transmit HIV. So we've grown up from there, and we can do that with this section of the Act.
One of the conversations I've had on many occasions is the disjunct between U equals U on the one hand and a criminalisation process on the other. That to me seems to create a contradiction around what it is that U equals U has actually achieved and what it means in biomedical terms, because what we know is that what it means in biomedical terms is not what it means in social terms, because a disclosure of being positive is viewed in the worst possible light. And that's not to, again, detract from the experiences of people living positive that have, in fact, been devastating and trauma-filled because of the attitudes of others and because of a world which, in fact, demonises this particular condition. But because of the fact that literacy, community and social licence hasn't caught up with what U equals U actually means. So I think that there is a really significant role for public education in the breaking down of stigma and of bias and of this ingrained prejudice that, again, it's a hangnail from the 80s and from those ads that all of us saw and, that were devastating for so many of us who, loved and lost people. These are things we need to get better at. I think consent law reform is something which has brought us a long way. So I don't think that, in fact, this is something that should be altogether chucked out. I think that we really do need to have a robust framework in place that is about affirmative consent, that is actually about finding a balance in a power imbalance, which often leads to, again, significant hurt and trauma and distress that can often last over a lifetime. So I think that there are a couple of things in there that need further work. One is the U equals U versus HIV as it's more broadly understood. Another is the importance of having a robust affirmative consent framework. And another, to pick up on your point, Fiona, is the fact that the LGBTIQ+ strategy, one of the 4 pillars of that is actually to reach into legislation and to continue to remove legislation that causes or has the impact of causing discrimination based on LGBTIQ plus or, non-LGBTIQ plus suppositions about the way in which the law should work. And Paul, I do know that, you've been a very, very active participant in that work of the Justice Working Group, the task force. I think there are so many people across our communities who've been very actively involved in that. And we have achieved 19A. We have achieved a range of other law reforms that are important. This is about continuing that discussion. We've got the framework in place to continue it. But again, to go back to the point that Fiona has made, if we are not considering our ballots around the way in which this work can continue, then we face the very real risk that we will see things go backwards. And we fought too long and too hard for conversion and suppression practices to be banned, for 19A to be repealed, for the apology for historical convictions. Again, all of these things loaded with stigma, loaded with vilification, loaded with this idea that we should in fact just shut up and live in a world that doesn't accept us. And that's where that work needs to continue, and that's why the strategy as a 10-year focus on all that we are and all that we do and all that we've come from and everywhere we're going is incorporated into public decision making.
Thank you. Okay, so it's over to you. We've got a few minutes now. If there are any questions, just put your hand up and Colin will bring you a microphone. So just wait till you've got the mic. Keep the questions brief. Please make them questions, not comments, and ask the panel to just really quickly respond.
Okay, just very quickly. I noticed on page 6 you've got the commitment to abolish the co-payment at Melbourne Sexual Health Clinic, which is fantastic. It's a state-of-the-art facility. That would be great for people living in Zone 1. How do we reach patients beyond the Kale Curtain in the regions and in the outer suburbs? Kale Curtain. Fiona taught me that one. But yeah,
it's a Northern Metropolitan thing.
if we want to get yeah, for the patients on V-Line, because I know someone who lives somewhere out the back of Wangaratta, and I couldn't tell you where, but it's an all-day thing for her to get to her medication and to see her doctors, and it's a real impost. So how do we reach those regional areas successfully if we want to get to zero transmission?
Who would like to respond to that?
Well, I think that, Tim, would you agree that that's one for Harriet? Yeah. She's the regional.
I know, regional development minister as well. So there you go. You get 3. Yeah, that's right. You want to talk about V-Line? I'm your guy. Anyway, so I think it's a combination of things. I think where we can be innovative in the way in which medical care and treatment is accessed, including through telehealth, that reduces the tyranny of distance and the time taken that often is in and of itself a source of great disadvantage. We have, however, decided we're going to cap V-Line prices at Metro prices, though, so that does come down. Gratuitous plug endeth here. But what I will say is that we can use technology, but we also need to make sure that our workforce is upskilled, is expanded, and is decentralised. And I think that's a really important part of it, particularly where in remote, rural and regional communities, they're very, very small. And if you know the pharmacist or your spouse or your partner or your friends or your nibblings know the pharmacist or the doctor, then, good luck in making sure that you can actually... Oh, okay, there we go. So you were one of the good ones, right? But again, it's about making sure that we have that cultural improvement around patient privacy, around the dignity of being able to access healthcare, and that also goes hand in hand with reduction and removal of stigma. So I think there are a few ways to do that, and I think COVID has really encouraged us to think much more effectively and beneficially about overcoming distance.
Is there another question from the audience? Nope, that's okay. Oh, yes.
I'd like to ask about testing and late diagnosis. And there are certain groups in the community that fare worse and are less well tested, and I'm particularly talking about women and heterosexual men. Can you please talk to that?
My initial thought is that this is actually around doctor education, because doctors look at women and think, well, you couldn't have HIV. You've got the wrong chromosomes, and unless you're a sex worker, then of course you probably do have HIV. So I think there is a good body of work that needs to be done around educating our general practitioners and our sexual health workers to be thinking about women also being at risk of HIV, because you're absolutely right that is hidden, and people don't consider women at risk of HIV. I think it's a body of work that needs to be done around education, because yes, we are seen as people who would not contract it.
I think that's a really, really important question, and I think it's a question again about what it means to define stigma, but also what it means to actually provide services. And just yesterday, in fact, we announced a women's health package, which it includes women's health hubs around the state that are walk-in, and they're free, and they will include access to treatment, to testing, and to support for sexually transmitted diseases and for bloodborne diseases as well. So this is where, again, we need to make sure that we are evolving in the way in which services are provided, and this is where that's precisely the sort of commitment that goes toward delivering a package that includes the way in which testing occurs, and also what does it mean to provide community education to practitioners, to specialists, to community members, and how do we actually break that down? And it's not just about women, it's not just about straight men. It's also about a range of other intersectional slicing and dicing that occurs across the community at large, and that's where a reticence to actually be tested or to identify the importance of being tested needs to be tackled across all sorts of different dimensions, whether that's the cultural lens, whether that's First Nations folk, rural or regional, people with disabilities, and neurodivergent communities as well. We need to make sure that we are providing resources and information in language, in culturally safe ways, and in systems that encourage and permit and provide a non-judgmental environment for conversations that involve testing and involve early access to that information in order to provide treatment pathways from there.
Thank you. I agree with what we've just heard, but I'll just add, I think there could be space for home testing here. That's for the women who know that they need to be tested or want to be tested. But also, for those who don't, I think we need to reduce the practice of having a sexual health screen or an STI checkup without an HIV test. HIV is sexually transmitted just as, gonorrhea and chlamydia are, and there's not much justification for doing testing for, a swab for gonorrhea and chlamydia and not doing a blood test for HIV.
We've got one more question down here, and then we will, at the end of this, we'll try and keep this fairly brief, but also then just a really quick final statement from each of you.
Hi, I'm from Living Positive Victoria. We know that at the point of diagnosis, of HIV diagnosis, that referral to clinical care happens quite quickly, and we've talked a lot about the importance of, people achieving undetectable viral loads, but for that to occur, people have to actually be able to arrive at care, and it's not straightforward. My question is, what can we do to ensure that referral to peer support, active referral to peer support, occurs at the point of diagnosis as standard of care? What can we systematically implement to ensure that that happens? Harriet, please.
Thank you. That's, again, such an important question, and it's one which goes across private and public health, so therefore it kind of traverses a couple of different layers of government. It's also, though, about the sharing of information and providing a better pathway for people to access information, care, treatment and follow through. And that's something we're trying to ease in terms of a consent to the provision of information across various providers in the course of that process. This is a really fine balancing act that needs to be achieved, and we saw analogously discussions about that in the Mental Health Royal Commission and the Family Violence Royal Commission. People were, we'd heard time and time again, really fatigued by needing to tell their story 1,000 times over in order to get one step further along the path toward that whole person care, and that discussion that didn't require a different focus every time a conversation was had. So this is about making sure that we have better processes in place, and I think many parts of the health and human services sector are getting better at it, but it's also about recognising that this is a really, again, I don't want to sound crass, but it makes sense to bean counters when you can have an economic benefit to it. And if you're reducing duplication or removing duplication by having a single point of contact or an opportunity for that to then form the basis of information that's used to provide care to a consumer or a client or a patient, that's where you get better outcomes. So this is where I think government is, and government's, it's the behemoth. Every level of government is enormous and complex and unwieldy. It's like Howl's Moving Castle, and it takes a long time to turn things in a different direction. But it is about saying that we are getting better at it. How do we make sure we combine those elements of permission and privacy and disclosure of information, of protection of patient information, particularly where only partial information is consented to disclosure, and also how do we make sure that we have that follow through, that we're not simply doing things in a really staccato fashion that finishes and then doesn't follow through, because we know that young people living positive become old people living positive, and you know that in and of itself is an extraordinary thing, but we also need to provide whole of life care, and that's something with a really long tail to it, as it should be, but we need to also make sure that in every provision of service and health, not just with HIV, not just with those discussions around wraparound care in that setting, but more broadly we have that in place as well.
Can I just add to that? I think we're at peer workers and peer support has been a fundamental foundation of our HIV and AIDS campaigns and the work that we have done for decades. Living Positive Victoria is a fine example of that. I think that now is the time for us to really be campaigning around this. We've just recognised the importance of those with lived experience in our mental health legislation. We're seeing this, we're trying, it kind of skipped over peer support and lived experience people in our AOD sector, but I think that's an area that we're campaigning on as well. But I think now is the time when governments have actually recognised the importance of lived experience and the importance that the important role that people with lived experience have in the provision of care. Now is the time for us to be actually ensuring that this is embedded in our care for it around HIV as well.
Look, I won't add anything to that. I think we've heard it enough. Yes.
Do you want to each make a just really quick closing statement? I'm happy to just give you a minute each.
All right. Well, I'll give you. You might not be expecting this. We've heard a bit about the upper house. Lower house MPs have to sift through all the emails about the dog shit on the footpath to. Yeah. It just hurts more when we ignore them, that's all, in the lower house. In the Victorian lower house, I'm drawing a little graph with my hands. There are 55 Labor MPs, 27 Liberal National MPs, and 3 Greens. You need your Greens. If you want to know about how people are elected to the upper house, don't take it from me because you won't believe it. Just Google Glenn Drury. Druery. Just Google that name and that'll explain the menagerie of the upper house. I'll conclude there.
Challenge accepted. No, I don't do that. Vote 1 to 5 below the line. You've got 5 representatives in the upper house in each of your regions. There's 40 of us. We ultimately pass the legislation, so it is a very important upper house because it can stop legislation, and it has. And we have seen important legislation being prevented from passing because the upper house has been a bunch of dickheads. So be careful with your vote. Actually, there's only a few dickheads, really, but they can really disrupt things. And be careful because we could see more. So you've got 5 representatives in the upper house. Tell your friends, just vote, pick 5. Have 5 votes instead of just 1. I mean, it's much better than the lower house. It's much better value for money, really. You get 5 votes. As someone who has been involved in the HIV and AIDS sector since I was young, I am excited by the conversations that we're having. I'm excited by these priorities because U equals U, the idea of elimination is something that I had never dreamed of. And the one thing that we didn't touch on was ageing. And for many of our HIV positive friends, they didn't actually get treatment at first diagnosis, or if they did, it was shit, it was AZT, or it was something that had such terrible side effects. So I think it's an area that I'm keen to better understand. We have an ageing population. I'm keen to understand that on a general community, but I think particularly in this area, this is something that I suppose I'm getting to that age that I do think that we need to consider that, and that goes with stigma, that goes with discrimination, that goes with many people who've not been able to disclose their status for maybe decades and maybe never have. So I think that's an area that, it's a special area that I'd like to focus on if I was re-elected.
Fiona has described it as a bit of a zoo. I'm going to put a diplomatic gloss on it there because... Star Wars bar. Ibags being the little blue dude with the trunk playing the trumpet in the corner. Now, we are very much at a crossroads. We have a lot at risk. We've come a long way, but we've still got a long way to go. And I know that all sounds very trite, but it's true. We are in the process of leaning into conversations around cultural change. We've had a number of pretty significant culture wars in the history of all of our culture wars, including as they relate to LGBTIQ+ inclusion and visibility in our school system, the operation and access to healthcare services, the way in which we're working our way through, as I said, the statute book to eliminate discrimination. Things are happening all around us, and they have been happening all around us for the benefit of our communities for the last 8 years. And it's that exponential momentum which is so important to hold on to. It's also, though, about being guided by and walking with communities in the way in which decisions are taken. And I don't ever take for granted the fact that I'm the first out woman in the Victorian Parliament, the fact that I'm the first out Equality Minister, the second only Equality Minister ever in Australia, the fact that we have an LGBTIQ+ Commissioner for Communities, we have a Pride Centre, we have all sorts of access to leadership programs, to healthcare services, to the way in which lived experience is within our trans and gender diverse healthcare sector, for example. We need to make sure, though, that this work continues, and this is the work that gradually dismantles stigma, that gradually dismantles discrimination. And I have a saying that's not a saying, I just made it up, and you might find it to be bollocks, but the thing for me is that you eat a wall 1 brick at a time. And you see, it doesn't make sense to any of you, that's fine, but it works for me. 1 brick at a time. and we just need to keep going. And we are fatigued because we are a civil rights movement, and activism is something which we are perennially tied to. But that's why we actually need governments who are there to make decisions that reflect that activism and reflect that need for recognition and for visibility and dignity and access to good decision making.
Thank you very much. And as we wrap up, I'd like to say thank you to all of our panellists, to Harriet and Fiona and Tim, for turning up tonight. The Liberal Party were contacted. We did make a lot of efforts. I've chosen to stand here when I could have been sitting down, just because I think it's important to remember that not everyone is here tonight, and they did have the opportunity, and turning up is important. And I'd really like to pay tribute to each of you in the room, because you've turned up tonight, and turning up is the first step to making a difference in the world. So congratulations to all of you. I'm sorry we ran a little bit over time, but thank you for your patience. Please thank all of our panellists and yourselves, and enjoy a drink before you leave.